A continuación tenemos la presentación titulada Implementación de Hospital at Home, modelo medicalizado en el hogar, presentado por la doctora Eliza Shulman, Pipa, entre comillas, no sé, me imagino que es su apodo de cariño de la gente que la quiere, presidenta de la Academia Americana de Medicina Domiciliaria, jefe de la Oficina Médica de Medical at Home y pionera en el diseño de modelos de atención híbrida y tecnológica aplicada al Hospital at Home. Bienvenida, doctora Pipa.
Gracias. Thank you, Dr. Sonia, Dr. Claudio, Dr. Juan Fernando, and the entire team. I am your first English speaker, and I'm sorry my Spanish is not as good as David's, and I ask for your forgiveness. So I put your earbuds in, get your Interprify up. It works very well. I understood everything. So thank you again for your indulgence. I appreciate it. Today, we're going to really explore how hospital at home evolved over the past many years from this really pioneering idea to a scalable model in so many parts of the world, and what it takes from an implementation perspective to bring it to life. And this is really from one experience in the United States based on really my company's experience and my experience as a provider. And so I'll tell you where I came from and why I'm talking to you today. But I really want to ground it in some foundations of what we think are important for successful implementation. And then my colleague, Dr. Linda Descherry, is going to talk about the scaling and why it's important to think about scaling your programs. So first of all, my disclosure is that I'm employed by my company, Dispatch Health. They pay my salary. That's probably obvious. My journey in hospital at home started from the beginnings of my training in medical school. I actually got to do house calls. Oh, someone's approaching me. This is exciting. My microphone's in the wrong place. Thank you. And really got exposure to seeing patients in the home from the very beginnings of my medical training, and really fell in love with that environment. And so that all through my medical schooling, residency, and early career, I always had patients in the home as part of my panel. And even when I was in the hospital environment, I was still caring for patients at home. I ran a home-based primary care program, a home-based post-acute care program, and we were caring for patients in all different stages of illness, from chronic disease management to really watching them through acute exacerbation of their disease, and to when we thought they needed hospitalization, and we tried to manage them as best we could. But it's hard to do that. If I was working that day or if I was on call, I could pull medications off the shelves of my clinic and bring them to the home. I could rely on my other colleagues to help me. And I'm sure this is an experience that many of you have had, trying to kind of cobble together a solution. And I got to have the opportunity to work at an innovation center in my organization and figure out how we could put together a more organized hospital at home solution along with our home care agency. And that was the beginnings of my first company that I worked with, Medically Home, in 2016. And we saw our first patient in May of 2017. And we worked with them because they had some technology solutions that helped us figure out how could we avoid putting everybody in a car to send them to the home. So early opportunities in virtual health and figuring out how to work with different care providers. And over the last 8+ years to present day, we've grown bigger. And where we are now is a bigger company called Dispatch Health, and I'll tell you about that. But we are a little dot in the greater history of hospital at home around the world. And this timeline is really just showing you that timeline of the world picture. Hospital at home is not new, right? It dates back. And if you look back into the 60s and 70s, my colleague from Spain, we have a couple of people here from Spain, should be very proud because Spain and some of the places in Europe were some of the early adopters of hospital at home. And there were lots of places starting to do this overall. And as we got into the 90s, this is when some of the early work in the United States was kicking off. And even before COVID, myself and Dr. Descherry and others and Dr. Levine were really figuring out models of hospital at home in the United States that could work for our patients over episodes of care. When COVID hit and our hospitals filled up and the capacity was out of hand, our federal government opened up the opportunity for a payment mechanism. And in the United States, everything is hinged on the payment mechanism, as I'm sure you've heard, that allowed for the place of service for hospitalization to either be in the home or in the hospital. And that opened up the opportunity for a lot of innovation in this hospital at home space. And the growth of hospital at home to allow for what we're seeing today. And so you'll see in these last boxes, tremendous growth, both around the world where there's amazing innovation across, many, many countries, many of which you're going to hear about today, over the next couple of days, but also in the US where we've seen an explosion of hospital at home. Our own experience, and this is Dispatch Health and Medically Home, is that we have cared for about 65,000 patients in a true hospital at home or hospital alternative care model, meaning these patients really needed at least 2 overnights in a hospital. So as we call that in the States, inpatient hospital care. So we've also cared for thousands and thousands of other patients who needed observation care or early discharge care, some watching, maybe shortened length of stay in the hospital. And we're doing this across 54 major cities in the US and the surrounds, the suburban and rural areas around those major markets. And this is in about 30 states. So this is a picture of the United States. This is about where we are. So we've got pretty good spread. But as David said, we're struggling to get into truly rural areas, but we are working on figuring out that kind of scale. And so we are seeing growth both through interest from hospital systems. We are seeing our federal government introduce opportunities for payment and really interest in how we do this going forward. And we've worked with some incredible health systems and learning how to do this. And so from our first health system partners to our most recent health system partners, how we do the implementation has changed over these past 6, 7, 8 years tremendously. But there are certain elements of implementation that don't change, right? So if you think about the clinical model, I think many of our clinical models will look very, very similar. The inclusion, the exclusion criteria, how patients enter the model will really depend on how patients enter your hospitals right now, how patients are, when they get sicker, how they will escalate out of your program if they need to, and pathways like that. And so let's talk a little bit about that. These are one of the things that's really important when we're talking about hospital at home are the types of patients. Last night at dinner, it was so wonderful because we started talking about, okay, which groups of patients are we referring to? When we're thinking about patients in the home, what do we mean when we say hospital at home? And I think it's really important that we establish that. So I mentioned 2 overnights in a hospital. That's unfortunately really important in the United States because that's how our payment system works. That's what triggers the payment for the hospitalization. And again, everything is triggered on our payment. And so these are folks that we think about being eligible for true hospital care in the home. There's been a lot of work in the worldwide hospital at home movement defining what hospital at home is and isn't. There's a lot of great work on acute care in the home, emergency care in the home, post-acute care in the home. But when we're thinking about hospital care in the home, I wanted to give some patient examples because I think that helps. So our nurse who was transferred to the home from the post-acute care unit after surgery, right? So she's had a surgery, she needs several overnights after that surgery, she's transferred right home. A patient who has asthma and has developed pneumonia, maybe has a new oxygen requirement, is seen in the ER and goes right home to substitute her entire hospitalization at home. These probably sound very familiar to you. Some of you may think, oh, okay, that's a little bit different. A patient multi-morbid, COPD, CHF, probably a little bit of diabetes, hypertension, many, many conditions, right? An older patient who is admitted to the hospital to rule out many other conditions, and then on the next day is transferred home to finish out his hospitalization. These are probably patients you see a lot, and probably a lot of the patients you think about in a place here like Columbia, where you don't have the hospital beds to care for these patients, could we avoid that hospitalization altogether? These are patients we think about a lot as well. And then patients who are very complex, both medically and socially, who may have concurrent substance use disorder as well as medical problems that make them very complex. And so that's what I want you to think about. We have to build our hospital at home programs to make sure we're caring for all of these patients. This is a very busy slide, and you'll get to take it home and you can translate it and you can write it up however you want it. The reason I left it this way, this ugly, lots of words slide, is because when we think about implementation, we have to think about all of these pieces, okay? So we think about, I talked about, all right, we have the clinical model, we have the inclusion criteria, the exclusion criteria. We need to think about the onboarding pathways, meaning how do patients enter your model? If I've been to one of your hospitals or one of your communities where you're admitting patients from, I've been to one of your communities and one of your hospitals. Similarly, if you've been to one of my hospitals, you've been to one. I need to understand how patients enter the system each time and build the pathways. We need to think about the staffing models for these. Is it nurses, physicians, nurse practitioners, paramedics, community health workers? Again, last night we were talking about the regulatory landscape where we live. In every single one of those states, there's a different regulatory landscape and licensing structure for every provider type. And so we may have to change who's caring for folks. That's probably different all the places that you live. And so thinking about the staffing structure is going to be really important. What kind of virtual support are you going to have? I think virtual support is really important. If you want your program to scale, what visits need to be in person and what visits can you do virtually? That's very, very important. We think a lot about that. Your operational infrastructure. So the lab, I think a lot about pharmacy. How are you getting meds to your patients? Both the medications that they need for their acute hospitalization, but also their everyday meds. Are you going to rely on the meds they already have in their cupboard, or are you going to provide new medications to them? Medical equipment. Do they need new medical equipment like a commode? Are you bringing it to them, or is someone else going to deliver it? Food. So we make sure that we offer, and actually our federal government requires that hospitalized patients are offered food. They don't have to accept it. And I think food is such an important part of healing, right? Maybe family wants to bring food, but we want to make sure we're offering patients food. That's something you have to think about in your program. Technology. Are you going to have virtual care provided? Is there going to be a centralized command center? Are people going to work remotely? How are you going to integrate with an electronic medical record? What kind of remote monitoring are you going to have? I'm going to talk this afternoon about technology. Some people, I think, over-rely on the remote patient monitoring, but there's probably got to be some remote patient monitoring and some sensors and such in your program. And then what kind of data are you tracking? And how are you monitoring safety in your program? These things are very, very important as you're thinking about the implementation. And so we run work streams, about 10 different work streams as we're implementing with our hospital partners, and really cover all of these areas. Now, we have another work stream where we think about all the payment and regulatory considerations, which is a bit frustrating, but the reimbursement landscape is important. And I know for some of you, that reimbursement landscape will also be important. For some of you, it will be a public payer, and for some, it will be a private payer. It may be a web of private payers that you will have to interact with. And so that will be important, and the documentation may change for some of those. One of the pieces that's very critical that I don't think we talk enough about when we talk enough about implementation and successful implementation, and one of the key success factors for scale, which my colleague is going to talk about, is the organizational readiness and the culture change it takes for hospital at home. Now, there are over 400 of you sitting in here, which is incredible. But when you go back to wherever you are from, and you go back to the medical culture wherever you are from, how many people in your organization are ready to say, yes, we're going to hospitalize our patients at home? Because one of the things we say to the leaders of our health systems is, if you want a successful program, you need to commit to at least 10 to 20% of your hospitalizations are going to be at home. You are going to say that the default for certain conditions is at the home. You are going to instruct your emergency department physicians, your hospitalists, your folks taking care of patients who are very sick to say, you are sick enough to be in the hospital, and great news, we can care for you in a hospital in your home. That is the default, and that patients will opt out, or that we will look for exceptions to that. And that's a really turning over of what we normally see of the whole system. And for us in the United States, our whole system is contingent on keeping hospitals full. That's how they make money. And so to say we're moving all this business out is a real shift for those chief financial officers of the hospitals. And we have to convince them this is not only good for patients, which we know it is, we all know it is, this is good for the system. And that's really, really important. It's that physician change, that organizational change, I think is the most important piece. And that's the piece that you are all going to have to be evangelists out there helping us spread. That's why I get so excited when I hear that last year in Bogota, there were 1,000 people coming together in the international conference, that here in the domestic symposium, over 400 people, that I know next year and the year after it will be bigger and bigger and bigger. At the World Congress in Vienna, the biggest ever. You know, I'm the president of the American Academy of Home Care Medicine. Our hospital home track is the most popular track at our annual meeting in October, by far every year. We have an organization now, the Hospital Home Users Group, that David and Linda are the two of the founders of. It's growing leaps and bounds every year. This change is happening. We are not going back, but it's still a little bit of a fight over and over. And so this implementation is complicated. We say it takes 6 months, 4 to 6 months. We can do it faster, but it's better if we go in that time frame. And the secret is, part of what takes it a long time is the second column here, which is all about the EHR integration. The EHR build takes longer than I want it to. Most of our health systems in the United States are on Epic, and Epic determines how long it's going to take, and it takes about 6 months, and it costs a lot of money. And so that's what we are stuck with, and so that's a piece of this too. Now, once you have built this platform of hospital care in the home, there are so many other things you can do with it. Now, many of you, like myself, have come from a background in the home, doing home-based primary care, home-based palliative care, home-based all sorts of different things. And so you actually already intuitively know this because you're doing all of this automatically already. What I know is that once you set up your system to be able to care for safely the sickest patients in your healthcare system, you can open that aperture to be able to care for a very wide array of patients. And once your system has started thinking about discharging patients or transferring patients, into your hospital at home, they start thinking about more and more use cases. And where we get really excited is a successful implementation for us does not end when they open the door for their program and admit the first patient or the 10th patient or the 100th patient. The successful implementation for us continues because we stay with them and we provide advisory services over time, and we start to help them open up to more and more use cases, some of which are still that high acuity hospitalization in the home, but some of which are things that are more lower acuity post-surgical use cases, are oncology use cases, are things that are supporting patients over longer periods of time. I know here I know that you're already doing a lot of chemotherapy in the home. That's actually pretty new in the United States and something that we're more dabbling in, I would say, but that's something that we can really support the acute exacerbations in through really good hospital at home programs. So what I would say is implementation, do not underestimate the effort and planning that it takes, but it's not impossible. And I'm bringing you one view. I'm bringing you a view of what I think it takes to really think about a sustainable, scalable program. Now, if it's you and 3 colleagues and you want to just get going, yes, you should still think about all of these things, but you can do a smaller program and build it slowly over time. But I want to encourage you to think big and really think about that transformative change across your system, across these larger geographies and across your country, and really think about what it will take to do that. And that's why I'm so excited for the next talk, which is going to be on scale. Thank you again so much for having me and tolerating my English today. And I'm so delighted to get to meet many of you and learn from you. So gracias. Thank you so much.
Agradecemos a la doctora Pipa por su intervención.